Okay. Uh, Hope you are all doing well. I am Dr. Tayyeba, Fellow of Pain Medicine at Sheikh Zayed Hospital, Lahore. Today, the topic of our discussion is neck pain, and I'm starting with that presentation. Okay, everyone can hear me now?
Yes, Dr. Deva, we can hear you loud and
Okay,
clear.
ji.
Thank you.
Okay, ji. Okay, okay, okay. Thank you so much, Dr. Sadaf. Okay, ji, proceeding to our discussion. Neck pain is a topic of discussion. Neck pain is a very common entity we all encounter in our OPD settings, daily OPD settings, and it has multiple presentations, it has multiple etiologies, and therefore it has multiple management plans. Now, proceeding on to our discussion. First of all, we will see what will be the objectives of our discussion. The objectives will be discussion regarding anatomy of the neck, causes of the neck pain, various red flags in the neck pain, clinical features, examination, investigation, and the treatment. Okay, ji. I am proceeding on to the discussion among anatomy. Okay, ji. In the anatomy, we will discuss regarding the bones, joints, various ligaments, and various muscles that are very important with reference to the neck pain. In anatomy, the bones that are very important in the neck are the seven cervical vertebra. The first two, there are seven cervical vertebra, and the first two cervical vertebra, that is atlas and axis, they are distinct in the anatomy as compared to the all other vertebra. And all these vertebra are joined by two specific joints, that is disc joint and the facet joint. This joint is formed between the vertebral bodies by the intervertebral disc, and it is basically a cartilaginous joint. The next joint is the facet joint, जो कि form होता है superior और inferior processes of two adjacent vertebra. दो cervical vertebra के दरमियान में जो superior inferior cervical वो articular processes होते हैं, उनके दरमियान में facet joint form होता है. Then comes the ligaments. Among the ligaments, the important ones Among the ligaments, the important one is the anterior and posterior longitudinal ligament. Anterior longitudinal ligament is the one that is connecting the interior aspects of vertebral bodies. Posterior longitudinal ligament is the one that is connecting the posterior aspects of vertebral bodies. Then comes the ligamentum flavum. Acha, ligamentum flavum is the thing that is connecting the interlaminar region of the two adjacent vertebra. And the knuckle ligament, in case of cervical vertebra, knuckle ligament is a very important thing. It extends from the occipital region to the spinous process of the seven cervical vertebra. And ये basically एक septum की तरह होता है जहाँ पे बहुत different muscles of the neck आके attachment करते हैं. Then comes the transverse ligaments of atlas. Transverse ligaments of atlas basically atlas के दो lateral masses को connect करते हैं and they are a source of anchoring of the dens of the axis to the atlas. These are the important ligaments with reference to the cervical vertebra. Then comes the muscles of the cervical vertebra. These are basically categorized as anterior neck muscles and the vertebral muscles. Among Okay, this is the pictorial representation. Just we have regarding the anatomy we have just discussed, and this is showing the knuckle ligament, ligamentum flavum, various cervical vertebra, and the spinous process, interspinous ligaments, and the various joint capsules that are clearly visible in this picture. Like we can see the joint capsule of the zygapophyseal joint that is shown over here. The ligament, this is the knuckle ligament that is showing over here. Okay, then coming on to the causes, the various causes that are important with reference to neck pain. The various are categorized as anatomical causes, musculoskeletal causes, inflammatory, and the referred pain causes. Among the anatomical causes, they can be further elaborated as डिफरेंट जो एनाटमी के पार्ट होते हैं उनमें अगर कोई पैथोलॉजी आती है कोई प्रॉब्लम आती है तो वो एनाटमिकल कॉजेस में आ जाती है लाइक फैसेट जॉइंट आर्थ्रोपैथी हो सकती है इंटरनल डिस्क डिस्ट्रप्शन प्रोलैप्स इंटरवर्टिब्रल डिस्क सर्वाइकल रेडिकुलोपैथी
Excuse me, Dr. Tayyeba, your internet connection is not very stable, so we have lost your screen. Kindly share your screen and restart your presentation right from the anatomical causes. Dr. Tayyeba, can you hear me? Your microphone is unmuted. Kindly unmute your microphone as well.
Hello?
We can hear you now, Dr. Tayyeba. आपकी presentation अभी नहीं show हो रही.
शो नहीं हो रही है, अभी भी नहीं शो हो रही
Uh,
है.
नहीं अभी नहीं हो रही.
Now you can see.
Uh, मेरा ख्याल है अभी शुरू हो रही है.
Now you can see.
Yes, we can see the slides now.
Hmm. Okay. Hope everyone can see and listen me. Hear me. Okay.
G, we can listen to you now.
Okay. I'm proceeding. जी डॉक्टर सदफ should
Yes, yes, please, Dr. Deva. Please carry on.
Where is problem? Not the problem here network. We can't hear. Neither we can see nor we can hear.
Sorry, sir, there is some connectivity issue at Dr. Teba's and she is trying to reconnect. She is joining us back in the next couple of minutes.
Can you hear me?
You are audible now, Dr. Tayyaba.
Hello. Ji, now everyone can hear me?
You are audible now, Dr. Tayyaba, and we can see your screen as well.
Okay. I'm starting again, okay?
Okay.
Okay, ji, the objectives of our today discussion will be discussion regarding the anatomy of the neck, the various causes of the neck pain, the various red flags in the neck pain, clinical features, examination, investigation, and the treatment. Okay, with reference to the anatomy, we will see regarding the bones and joints. There are 7 cervical vertebra. The first 2 cervical vertebra are distinct with reference to their anatomy. Uh, there are 7 cervical vertebra that are connected by the disc joint and the facet joint. The disc joint is formed basically between the two vertebral bodies by the intervertebral disc. This is a cartilaginous joint. The next joint is the facet joint, जो कि फॉर्म होता है दो एडजेसेंट वर्टिब्रा के सुपीरियर एंड इंफीरियर आर्टिकुलर प्रोसेसेस के दरमियान में. The next comes the anterior and the posterior longitudinal ligament, the ligaments that are important with reference to the cervical vertebra and the neck pain. This comes the anterior and posterior longitudinal ligament. Anterior longitudinal ligament connects the anterior aspects of vertebral bodies, and the posterior longitudinal ligament connects the posterior aspect of the vertebral bodies. Then comes the ligamentum flavum. Ligamentum flavum is basically the interlaminar ligament that connects the interlaminar region of two adjacent vertebrae. Then comes the knuckle ligament. Knuckle ligament is the thing that connects from the external occipital protuberance to the spinous process of the 7 cervical vertebra, and it serves as a septum that connects the various muscles, that provides the site of attachment for the various neck muscles. Then comes the transverse ligaments of the atlas. Transverse ligament of the atlas basically connects the two lateral masses of the atlas, and it provides a site of attachment for the dens of the axis, that is the 7 cervical vertebra. Then comes the muscles of the neck. The muscles of the neck, these are categorized as anterior neck muscles and the vertebral muscles. This is the pictorial representation of the anatomy we have just discussed. And from here we can see the various ligaments and the structures we have just discussed, this is showing the this is showing the knuckle ligament, and they are the cervical vertebra, their spinous processes, their transverse processes. Here we can see the joint capsule of the zygapophyseal joint, and this is the zygapophyseal joint or the facet joint we have just discussed, that is formed between the superior and inferior transverse processes, articular processes of two adjacent vertebrae. Then coming on to the various causes of the neck pain. There are multiple causes of the neck pain. These can be categorized as the anatomical causes, musculoskeletal causes, inflammatory, and the rapid pain causes. अच्छा जी, anatomical causes. In anatomical causes, there comes facet joint arthropathy, internal disc disruption, prolapse intervertebral disc, cervical radiculopathy, vertebral disc fractures because of the trauma, and the interspinous ligament sprain. Among the musculoskeletal causes, the most important entity we often encounter in OPDs is the trapezius myofascial pain syndrome, a the patient present करता है that they have trigger points in the trapezius muscle, and they usually present with the neck pain. And on examination, we can find out the various trigger points in the trapezius, and therefore we can treat it appropriately with reference to this cause. Then the next myofascial myofascial pain syndrome that is important is the sternocleidomastoid muscle, and another that is important with reference to the neck pain is the occipitalis muscle myofascial pain syndrome. Then comes the inflammatory causes. Among the inflammatory causes, the two important conditions that are to be considered is the rheumatoid arthritis and the ankylosing spondylitis. Then comes the rapid pain. Rapid pain is also a very common entity with which the patient can present with a neck pain. And on detailed history and examination, we can find out that it is basically a rapid pain, such as sometimes the patient has the basic issue of the shoulder, such as the shoulder joint bursitis or the impingement syndrome. An initial presentation of the patient is the neck pain. In case of cardiac issue, the patient may present with a neck pain, and on detailed history and examination, we can find out that it is a myocardial infarction or any other cardiac issue. Among the lung issue, the Panco syndrome is a very common entity with which the patient can present with a neck pain that can cause the compression of the cervical sympathetic chain, and patient can present with a neck pain. Diaphragmatic irritation is also a very important cause with which the patient can present with a neck pain. Then comes the various red flags of the neck pain. Then comes the various red flags of the neck pain. The important red flags include the history of the trauma, infections, tumor, such as the cervical tumors can be, vertebral body fracture can be there, cord compression can be there, and fracture can be there that is leading to the unstable cervical spine. Another red flag is the presence of progressive disturbance of the gait, motor, and the sensory deficits. This can occur in case of unstable cervical spine that is leading to the cervical myelopathy. Another important red flag is the acute progressive neurological and cognitive disturbances, जिसमें hemodynamic disturbances भी हो जाती हैं. And the important condition with which this red flag can present is the vertebral artery dissection. Associated with the chest pain, this can occur in the case of various cardiac issues such as the myocardial infarction. And associated Horner syndrome, this can occur as we have discussed previously in case of Panco syndrome. That is the lung tumor present at the apex and is compressing the cervical sympathetic chain, and it can present with the Horner syndrome, and this is an important red flag which we have to consider. Now we will discuss the various clinical features with which the patient can present in our OPD setting or in an emergency department. In addition to the neck pain, patient can have various other symptoms that can be because of the compression of the nerve root or because of the compression of the cervical cord, because of the herniated disc or because of a bone spur. The associated symptoms or the other symptoms with जिसके साथ patient OPD में present कर सकता है या emergency department में present कर सकता है is the pain in the upper lip जो neck से radiate होके upper limb में आती है, या numbness, tingling, weakness, या difficulty with the balance and walking, or it can be associated with vomiting, nausea, vomiting, and vertigo. Then the important aspect with reference to the neck pain is the examination. As we all know, being a physician, the examination of a patient starts as soon as the patient enters the examination room. We have to observe the gait of the patient, the habitus, the body habitus of the patient, and the various other clinical features as well. In the gait of the patient with reference to the neck pain and cervical spinal cord, we have to observe that whether the gait of the patient is spastic or ataxic. If the gait of the patient is spastic or ataxic, or both combination of spastic ataxic gait, the cervical myelopathy element can be suspected in that patient. If the body habitus of the patient is cachectic, then we can suspect cancer. Okay, then there comes the inspection. In the inspection, we have to see regarding the skin of the neck, the head and neck posture, if there's any kind of muscle wasting. For example, if there are signs of inflammation, is there any mass we can see on the neck? If the muscles are wasted, we can suspect regarding any carcinoma or any cancer pathology, and we can have detailed history and examination regarding that. Then comes the palpation. In case of palpation, we have to do the midline palpation and the paramedian palpation. The paramedian palpation, when we are doing a paramedian palpation and there is tenderness, we can suspect that the patient may have facet arthropathy that is further confirmed by the investigations. If the patient is having axial spine tenderness. It can be because of the internal disruption, or it can be because of the bilateral cervical facet arthropathy. Then comes the range of motion. As seen in this picture, then in the cervical vertebra, the normal range of motion is the flexion, extension, right rotation, left rotated flexion, and the right lateral flexion. And if there is a problem in any of these range of motion, we have to assess regarding the cause. Then comes the special tests that are very important with reference to the neck pain. Among one of the very important tests is the Sperling test. This is a test that is basically used to test whether there is cord compression, cervical radiculopathy or not. That is nerve root compression हो रही है या नहीं हो रही. इसमें हमने करना कैसे होता है, like any other procedure, we have to first of all take consent from the patient and explain the procedure to the patient, and we have to counsel the patient that whether the patient feels pain, whenever the patient feels pain and wherever the patient feels pain, he or she has to let us know. Okay. And the procedure to do this maneuver is, first of all, we have to apply the downward pressure on the neck, and then we have to rotate the neck and extend the neck on both sides and see if there is any pain in the trapezius region or in the arm. The positive test is when the limb pain or the paresthesias is produced, and the negative test is that if the limb pain or the paresthesia is produced only during the maneuver, otherwise the patient doesn't complain of the pain. Okay, and this test is very important with reference to the neck pain assessment because this test has a high specificity and low sensitivity. With reference to the cervical radiculopathy, if this test is positive, it means we can strongly suspect cervical radiculopathy. साइन, इसमें हम क्या कहते हैं कि पेशेंट की जौन सी अपर लिम्ब पेनफुल है या जहाँ पे पेन हो रही है, वी आस्क द पेशेंट टू प्लेस द सिम्टोमेटिक arm on the head and we ask for any relief of the symptoms. If the patient is feeling के उसके symptoms relief हो गए हैं, it means this test is positive. This is known as the relief sign. The next test is for the checking of the cervical spinal cord compression. This is known as the Hoffman test. अच्छा, इस टेस्ट को करने का तरीका क्या है कि the upper limb, the middle phalanx of the middle finger of the arm, which is the suspected affected side, the physician has to hold the middle phalanx of the middle finger of the limb that is affected. Then, with the other hand, the physician will palpate the pulp of that finger and will see the flexion of the index finger and the thumb of the patient of the same hand. If there is flexion, the test is positive and we can suspect there is cervical spinal cord compression. The next test is Lehermite sign. In this test, there is production of paresthesias and dysesthesias upon flexion or extension of the cervical spine. And if we give command to the patient to do the flexion extension of the cervical spine and the patient is feeling paresthesias, dysesthesias or tingling sensation or discomfort in the arms or the legs, it means the test is positive and the test is depicting okay, it can be a large disc herniation or it can be a bony compression of the cervical spinal cord that is already narrowed or that is being affected by the compression extension because of the bony spurs. Another important inflammatory condition in which it can occur is the rheumatoid arthritis. Then comes the motor examination. In the motor examination, as a dentist, we have to grade it from 0 to 5. And the purpose of doing this motor examination, we have to assess the strength of the muscles as well as we have to assess whether there is any kind of lower motor neuron lesion or upper motor neuron lesion. In case of lower motor neuron lesion, as we all know, there is weakness, hypotonia, and fasciculation. And in case of upper motor neuron lesion, there is spasticity. Then coming on to the investigation. Investigations are very important with reference to the neck pain because these can tell us about, these can guide us about the various causes or the various triggering, various site of the pathology so that we can do appropriate management plan. The first, starting from the very basic investigation, is the complete blood count with ESR and CRP. We will test the complete blood count and ESR and CRP that are the markers of inflammation, and if there is any inflammatory cause that is the causative factor for the neck pain, the ESR and CRP will be raised and we can have a suspicion regarding the inflammatory causes. Then coming on to the imaging. Among the imaging, we will start with a very basic imaging, that is the X-ray imaging, and we will take the anterior posterior views and the lateral views. Then we will move towards the higher modalities of the radiological images, that is the CT scan, MRI scan, and the nerve conduction studies and the electromyography. Okay, we have just discussed that X-ray is the very basic and initial radiological image that we will advise to the patient. In order to find out that what is the site of the damage or what is the site of the pathology, we should have a very sound knowledge regarding the various structures that can be seen from the cervical X-ray. As shown in this picture can show the various parts of the cervical vertebra, various structures that can be seen in the cervical X-ray. As this is showing the various cervical vertebral bodies, from this we can see the articular pillars. This is showing the zygapophyseal joints. This is basically showing the lamina. These are the spinous processes. And this is the anterior arch of the atlas. And this is basically the dens of the second cervical vertebra axis that is being anchored into the atlas. This is another pictorial representation of the cervical X-ray, and as we have previously discussed, they are showing the various facet joints or the zygapophyseal joints, various cervical vertebrae, and their transverse processes. An important thing in this is the uncinate process. This we can see the uncinate process that is mentioned in pink. Uncinate process, these are basically the bony projections that are present on the posterolateral aspects of the lower cervical vertebra. And these are important with reference to maintaining the stability of the cervical spine. They maintain the stability especially during the lateral flexion, right and the left lateral flexion, so that the foraminal spaces remain open and they maintain the stability of the cervical spine. If there is hyperostosis of these uncinate process, the patient can present with the nerve root compression or the cervical cord compression, or with the vertebral or with the vascular insufficiency, as the vertebral artery is also present in the vicinity. एंड देयरफॉर पेशेंट प्रेजेंट कर सकता है रेडिकुलोपैथी, माइलोपैथी या फिर वेस्कुलर कॉम्प्रोमाइज के फीचर्स के साथ. अच्छा, this is the X-ray that is showing the one is unhealthy neck and the other is the healthy neck. The unhealthy neck, from the unhealthy neck we can see the curvature of the cervical spine is lost. Normally the curvature of the cervical spine is C-shaped or it is anterior lordosis. When this anterior lordosis is lost, it can be because of the muscle spasm, as a result of which the patient usually presents with the pain. And on ordering X-ray investigation, we can find out that the cause of the neck pain may be the muscle spasm, as a result of which the orientation of the cervical spine is lost. But with the treatment, when the orientation of the cervical spine is regained, the pain of the patient relieves, and the patient and the neck of the patient, we can say now the patient is having a healthy neck. This is another X-ray. We can appreciate the fracture of the cervical spine, cervical vertebral body in this X-ray, which is an important cause of the cervical pain, and the patient can present with the cervical pain. As we have previously discussed, that X-ray is a very basic imaging from which we can pick up many things, and therefore, if needed, we can move towards more advanced investigations. This is another cervical X-ray. These are the examples I'm just sharing with you. This is another cervical X-ray. This is basically showing the disc spine. The elaboration of this is diffuse idiopathic skeletal hyperostosis, in which the anterior aspects of the vertebral bodies fuse with one another. There is hyperostosis basically, and इसका diagnostic criteria ये होता है कि 4 contiguous vertebra या 4 adjacent vertebra should have this hyperostosis in order to label the spine as a disc spine. And we can easily appreciate that there four cervical vertebral bodies. These are fused with one another on the interior aspects, thus forming the disc spine, and this is an important cause of the pain in the neck. This is the picture of the MRI cervical spine sagittal view, and we all know that MRI is a radiological modality जिसमें हम soft tissues को ज़्यादा अच्छे से देख सकते हैं. And if we are suspecting any kind of herniated disc, radiculopathy or myelopathy, we can advise patient MRI imaging, so that we can identify the soft tissue compression, the site of the soft tissue compression, and where we have to do any management if needed. This is an example of the MRI where we can see the herniated disc that is causing the compression of the cervicospinal cord and thus causing the myelopathy and the neck pain, and the patient may present with the radiculopathy as well. Then comes the treatment. The treatment can be categorized as non-pharmacological treatment, pharmacological treatment, interventional. Among the intervention, there comes two options: non-surgical treatment and surgical treatment. Non-surgical treatment consists of
There is some connectivity issue at Dr. Tayyiba's end. She's working on it and she'll be back in the next couple of minutes.
Apology for disconnection. The internet is making some issues. I'm starting from the treatment again. Okay. Okay, ji. Apology again for disconnection. The internet is making some issues. Acha ji, I'm starting from the treatment again. As we have discussed that for any kind of treatment, we have to start from the very basic non-pharmacological maneuvers. The treatment can be categorized for the neck pain can be categorized as non-pharmacological, pharmacological, interventional. Among the intervention, there is non-surgical and surgical options. And for the presentation point of view or for the discussion point of view, we will discuss the non-surgical ones. Non-pharmacological. Among the non-pharmacological, posture modification is a very important thing. Sometimes patient का occupation या patient का way of sitting या way of doing the various life activities are basically a triggering factor for the neck pain with which the patient is presenting. And if we modify that activity and if we modify that posture, the neck pain of the patient gets relieved a lot. Such as depicted in this picture, sometimes we are using phone or we are using our laptops or we are using any kind of our screens or any kind of activity. As we tilt down our angle from the neutral position to the downward position, we can see the force on a neck gets increased. As the force on a neck gets increased, the pressure on a neck gets increased. This is a very important source of the pain with which the patient can present in our OPD settings. Then comes the massage. Massage is a very important factor for which the topical agents are available. And if we do the massage in the direction of the various nerve fibers wherever the pain is present, like as in the trapezius region, the effect of the topical agents is very good. Then comes the physiotherapy. The physiotherapy is a very important factor among the non-pharmacological maneuvers because it can strengthen the muscle and it can improve the range of motion. Then comes the heat padding. The heat padding का purpose क्या होता है that it basically increases the blood flow in the muscles, as a result of which the muscle activity can improve. Then cervical collar is a very important thing that is used as a non pharmacological maneuver because ये नर्व रूट कंप्रेशन जो नर्व रूट कंप्रेशन की वजह से अगर पेन हो रही है तो नर्व रूट पे जो प्रेशर आ रहा है उसे डिक्रीज करता है, एज अ रिजल्ट ऑफ विच पेशेंट प्रेजेंट्स विद अ डिक्रीज इन नेक पेन. Patient it gets reassured. Then comes the acupuncture. This is the picture we have just discussed that as we increase the angle from the neutral position to downward position, the force on our neck increases, and this is a very important factor that causes the neck pain. The neck is the pharmacological maneuver. For the pharmacological maneuver, we all know that we follow WHO pain leader in which there are three steps and a fourth step is also added. The first step or the very basic step is for the mild pain in which we usually use the non-opioid therapy with we can use adjuvant therapy that is a plus minus condition. If the patient is having mild to moderate pain or if the pain is not settling with the non-opioid, we move towards the weak opioid or the non that can be used in combination with the non-opioid or the adjuvant therapy. And if the patient is having moderate to severe pain, we move on to the third step. The third step is using the strong opioid with non-opioid plus minus adjuvant therapy. As we have discussed that a fourth step is also added in the WHO pain ladder, and this fourth step is basically for the interventional steps. Like in our specialty, if the patient is not getting relief by the non-pharmacological and by the pharmacological maneuvers by the various drugs, we move towards the various interventions that we will discuss further. अच्छा जी, intervention non-surgical step which we have discussed previously, that for our discussion point of view we will discuss this. This can be further categorized as the conventional steps and the advanced steps. In the conventional steps, we know that neck pain has multiple etiologies, it has multiple presentations, and it has multiple management plans. Therefore, multiple conventional methods can be used that depend upon the cause, and this can be both diagnostic as well as therapeutic because sometimes the neck pain that is presenting has multiple etiologies and we have to go step by step addressing every kind of etiology. The conventional non-surgical treatment that can be done, examples include cervical facet block, selected nerve root block, cervical epidural, greater and lesser occipital nerve root block, greater and lesser occipital nerve block, trigger point injections if the patient is presenting with the associated trigger points in the trapezius muscle, and the dry needling. Then comes the advanced non-surgical process. This include the platelet-rich plasma therapy, Botox therapy, conventional radiofrequency ablation, pulse radiofrequency ablation, spinal cord stimulator, and the peripheral nerve stimulator. These are the various advanced maneuvers that can be used while the treatment of the neck pain being a pain physician. That's all for our discussion from my side. And I thank you all for your patience and for giving me time. Hope everyone have some idea regarding the neck pain I've discussed.
Thank you very much, Dr. Tayyaba, for a detailed review and a wonderful presentation. Uh, the house is now open for comments and questions. Do we have any comment or question?
Thank
Assalamu
you,
alaikum.
Dr.
Thank you. Ji, Dr.
Hello.
Khalid, please.
Just, I will remark that it was a very good presentation, and so she has covered almost all the aspects of network management. So it was a good presentation.
Yes, it was a very good presentation, very elaborate. I just wanted to know anybody in the house can share their experience with PRP of the neck pains. Dr. Khalid, would you like to elaborate on it?
I personally, I have no experience here with PRP. I'm not convinced.
Exactly, I
Just,
wanted to know how good is PRP in the pain treatment, especially in the neck pains.
I haven't used it. People are using it for passive joint pain and knee arthritis pain.
Is
I
it
have
is
not
it
used.
is it of any help in any kind of pains?
Like other interventions, in some patients they work very well, in some patients they don't work. Just like any other.
Thank you so much.
Assalamu alaikum.
Walaikum salam, sir.
This is Dr. Jamil Sabit.
Ji, ji,
And
sir. Hope
I'm
you are fine,
sorry, I
sir.
was just actually I got late from clinic and I missed most of the talk, and I joined the talk as soon as I just got home. It was from pharmacological treatments options.
Ji,
And
sir.
the way Dr. Tayyaba has covered it very nicely, I really appreciate. And
Thank you, sir.
regarding the PRP, I don't personally do, but the PRP is good in those patients who have some congenital issues regarding the weakness of the muscles and all that. And so like young people with the long neck and Marfan syndrome type of cases. So PRP is good for those patients. And PRP mostly is the best in the sports injuries, where the injuries there, partial injuries are there, is good for the healing of that area. But in the neck, neck pain, it's not a very convincing treatment. And sometimes the neck pain, is because of discogenic pain. And discogenic pain needs definitely treatment of the disc. So PRP for the intraduscal PRP does help with these patients by healing the tears and all that inflammation inside and regrowing the this disc. So that is good for the such cases for intradiscal procedures. PRP is good. And I personally prefer diagnostic block and median branch blocks and like C2, C3 RFAs or like this. And the important thing is just what is the cause of neck pain? Is it the disc, or is the facet joints, or is the muscles, or some whiplash injuries? So accordingly, we can make the treatment plan for the patients. Simple epidurals, I had a long study of 200 cases for neck pain only. So I found that around 45% patient, they needed some other things also, like uh, trigger point injections or median branch blocks or facet joint injections for the neck pain, along with the cervical epidurals, because cervical epidural, is good for radicular pain also. So it's nice, but the important thing is that we should go for the best available treatments, and learning is very important, especially for the young people, to learn the more and more complicated cases and get control on it under the supervision of their seniors. And all the best. This is the few things I wanted to share, and good luck. Thank you.
Thank you so much, sir, for your very kind of opinion.
Thank you, Jamil, for a
Thank you
good
very much,
remark.
sir,
I
for
would
your
add-
valuable input and sharing your experience with us.
I would just add one comment that, especially for juniors, there are multiple treatment of in syndromes, but the important thing to learn is assessment of pulsation. What to do, what not to do, when to do, when not to do. ये चीजें सीखनी है, असल चीजें सीखनी है, assessment. प्रोसीजर तो टेक्नीशियन भी कर लेगा, सारी चीजें होंगी, लेकिन अच्छी चीजें सीखने वाली है. What to do, what not to do, when to do, when not to do. Thank you.
Thank you, Dr. Tayyaba. It was a really nice presentation and good approach to the patient. Cover all the aspects. मैं प्रोफेसर खालिद बशीर साहब से एग्री करता हूँ कि इट्स अ वेरी इंपॉर्टेंट थिंग. ट्रीटमेंट इज अ लास्ट पार्ट. इंपॉर्टेंट थिंग is कि पहले आप आइडेंटिफाई करें, अप्रोच हो, एंड देन द मैनेजमेंट आ जाती है. रिगार्डिंग पीआरपी, डेफिनेटली पीआरपी की डॉक्टर जमील साहब ने भी डिस्कस किया. इसमें स्पोर्ट्स इंजरी में ज़्यादा इंपॉर्टेंट रोल है. टेंडन इंजरीज, मायोफेशियल ट्रिगर पॉइंट्स में फिर भी रिजल्ट्स हैं. एंड आउट ऑफ द वर्ल्ड जो है degenerative disc disease में intraduscal, they are doing PRP and this claims some good results. लेकिन authentic अभी कुछ भी नहीं है, and but some convincing results are there. So it's under trial as such. I don't know how many people have done intradiscal PRP in Pakistan, लेकिन out of the world they are using. And I tried few like trigger points में myofascial या tendinitis के अंदर और partial tears may be fine result, but it needs sessions. It's not a single setting, and you need 3 to 4 weeks interval and 5 to 6 sessions. So it's a long term here and required healing. Thank you so much, Dr.
Thank you, sir. Thank you for your guidance. I really thank you, all the worthy seniors, for their precious time they have given to me, and special thanks to my worthy supervisor, Dr. Syed Mehmood Ali, for guiding me for all the presentation. And regarding PRP, being a very small knowledge I have, जितना मैंने आर्टिकल्स में और इन सारों में देखा है कि इट्स अ वेरी इमर्जिंग स्पेशलिटी, एंड एज सर यू हैव सेड multiple sessions are required, and it requires the patient education, and with the time I think this thing will flourish in a country that after multiple sessions of PRP patient gets relieved, and it is a very good and important approach, but it will develop with time. It will develop with time.
And definitely, Dr. Deva, thank you so much.
Any other senior want to give their kind opinion, you are welcome.
Somebody has asked whiplash injury management question. Can you hear me?
We can hear you. Please
Yes, yes.
जी sir.
Mostly
जी
the
sir.
whiplash injury is a traumatic injury, and it causes damage mostly to the facet joints, and sometimes it is very, if the bang on the back or the some vehicle is very strong, then maybe dislocation of the vertebra also is there. And but for the simple things, simple type of cases, facet joints are the mostly injured in these whiplash injuries, and uh, and sometimes the ligaments are also torn. If it is a fresh injury, and on MRI there is an evidence that the facet joint along with the uh, uh, along with the ligaments or torn ligaments are there, then the best treatment would be the facet joint pain relief with the help of radiofrequency ablation of the median branches, as well as putting half cc of PRP in the injured areas, and along with that, wearing the collar and soft collar and the isometric physiotherapy exercises. These do help these whiplash patients a lot. And sometimes patients have a cervicogenic headache also with along with this local neck pain injuries, and mostly it is because of upper C2, C3, or C4 areas. And in these cases, radiofrequency ablation of C2, C3 does help for the occipital area pain. So the whiplash injury has management, and for the chronic cases, old cases, radiofrequency ablation is one of the best treatments. And if the muscles are weak or muscles are tight, so you can go for Botox also with the low dose Botox, or simple local anesthetics, or dry needling. Sometimes people do. But when you relieve the pain of the facet joints, definitely bifidus muscle they get relaxed, and patient they do feel a good relief from the neck pain, and they improve their neck movements. This is some few things about the PRP. About the whiplash injury.
I've just seen in the chat the question from Dr. Shahid Dar, neck pain versus shoulder pain. Sir, I think so. You want to know ke, neck pain versus shoulder pain, how to differentiate it?
Any concern regarding shoulder pain and differentiation between the shoulder and the neck pains, if you have confusions?
Acha, sir, as I've said previously that I'm basically a fellow, I'm just in a learning phase. As far as I have seen the patients, from the history and from the examination, we can differentiate whether the cause is purely shoulder, whether the cause is purely cervical, or whether it is a combination cause. Sometimes on history and on the basis of various examinations, such as if the patient is having shoulder bursitis or the patient is having range of motion limitation of the glenohumeral joint, it can be elaborated from the examination. And if the patient is having, in that case, patient usually presents with a neck pain that is not so severe, but the pain is severe at the shoulder point. But if the patient is having cervicogenic origin, we know that supply of the shoulder also comes from the cervical plexus. That comes from the cervical plexus. And if the patient is having pain because of the neck causes or the cervical causes, on examination and investigations, we can find out that. Hope so, Dr. Shahid, you have got some answer.
Regarding the pain both in shoulder and the neck, the best thing is that if the patient has a neck pain as well as shoulder pain, so sometimes C5 pain is in the shoulder area, but pathology of the shoulder is not there, like rotator cuff syndrome, movement is okay. Patient can move his arm very nicely, and there is no local tenderness like bicipital tendinitis or something like that. And patient has on the pain coming from the neck. So mostly it is from the C5, which is on the shoulder area. So you can examine the patient if the range of motion of the shoulder is fine, and patient can nicely move his arm, and but does not have pain. And another very important thing, that patient with cervical radiculopathy, they if they put their that hand on the on their head, they feel relief, because their traction on the nerve root decreases, and it helps them. But with the shoulder pain, the pain increases because of a hyperextension of the shoulder. So this way is all clinical examination, like as Tayyaba has told, the clinical examination and history are very important. But if there is confusion that shoulder has everything looks fine and the pain is still there, so C5 pain can be one of the reasons for this. And even sometimes it is only the shoulder pain, there is no radiculopathy pain, but because the trapezius muscle and all that muscle, they get tense also. The patient can have neck pain also because of these muscles. So it all depends on your clinical examination and coming across your patients again and again, and you have the experience, then all these things, it does matter. But sometimes I have treated many patients who had rotator cuff as well as who had C5 radiculopathy also. So it all depends on the examination and clinical history and all that. Thank you.
Acha, and other question from Dr. Abdullah Bilal, which I can see in the chat, is that how we can differentiate muscle pain from guarding. As far as I've seen patients, the guarding is a phenomenon in which the entire muscle bulk gets stiffened. ठीक है, वो stiff हो जाती है. But in the case of trigger points, we can see a particular fiber or a particular band of the muscle that is getting taut, and that is basically the point source of the pain for the patient. And these trigger points are usually the active and the latent ones. Active means that on palpation or on the examination, there is a particular point where the patient feels pain. These are the tender points or the trigger points where the maximum pain is felt. And in case of muscle guarding, the entire muscle bulk gets stiffened when there is palpation. Hope Dr. Abdullah Bilal, you have understood.
I think you smartly answered his question, mashallah.
Thank you so much, sir. It's all because of your guidance and my very worthy supervisor. Another question from Dr. Shahid Dar. Sorry, I've just seen the chat now. That's why I'm answering late. Dr. Shahid Dar, where the Whiplash, where the PRP injections can be done. Dr. Shahid, Dr. Jamil has just recently said that if we do the intradiscal approach for the PRP injections, that gives a very good approach. But as I have studied the various articles, as far as I've studied, it is a very emerging thing, which is basically developing or flourishing in our specialty. So as the time progresses, more and more cases will be seen. The more intradiscal approach is a good one.
Thank you. I got your answer, but I also one more question regarding differentiation. Please, anybody see, if you can differentiate more between the myelopathy, cervical and cervical radicular pains, more differentiation points, so that we can sometimes confuse these diagnoses, and also some comments on psychosocial management of the cervical pains.
Dr. Abdullah, in our discussion, we have discussed two methods. One is the Sperling test that can depict regarding the cervical radiculopathy, and other is the Hoffman test that can give us indication regarding the cord compression, that is the cervical myelopathy. These are basically the examination steps, and further from the investigations, we can find out whether it is a cervical radiculopathy, that is a nerve root compression, or whether it is a cervical myelopathy, that is the cord compression. Hope Dr. Shahid, you are satisfied. Anyone of the senior wants to give opinion regarding this?
I have seen patient in Korea who had cervical myelopathy, and they had a cord compression because of degeneration and because of compression on the spinal cord, and they had felt difficulty in walking also, and the equilibrium was disturbed and the walk was not normal. So myelopathy is just a sort of syndrome when there is compression of the on the spinal cord. So it is not one entity or one-sided, or mostly it is bilateral. Symptoms are there, and mostly the weakness is the most prominent feature. Muscular weakness is the most prominent feature instead of pain in the myelopathy cases, especially in the cervical myelopathy. And I was astonished to see that the staggering patient and walk was there, and when investigated, there was compression in the cervical region, causing compression on the motor areas for the lower supply. And it can involve both arms also, but commonly if it is the lower side, then it is commonly the gait disturbance and weakness. So myelopathy pain is not very prominent, but in radiculopathy, the pain is the more prominent thing. Yes, if it is very severe compression, then there is motor loss also. So that is another thing, but it is in a specific area or in a specific dermatome. But in myelopathy, it is a broad, it is a wide-ranged weakness of the muscle most of the time. And you can confirm on the MRI and syringomyelia, like things like this, and all that damage to the any disease of the spinal cord, they can lead to all these weaknesses. Weakness is very prominent in the myelopathies and pain in the radiculopathies.
Thank you, sir, for your kind opinion.
Thank you very much once again, Dr. Tayyeba, and to all our buddy seniors for their valuable input. I think we can end our session for today now.
Thank you everyone for the time, and goodbye from my side. Take care, everyone.
Thank you very much, Dr. Tayyeba.